Let's talk about GBS. So, background, 30% of pregnant women has GBS, 50% vertical transmission rate. This is usually during labor or after rupture of membrane. GBS positive in previous pregnancy has a 50% risk of being positive during this pregnancy. 2% will develop GBS early onset disease if no antibiotic prophylaxis. This translates to 23 out of 100,000 live birth infections in 2015. So invasive GBS disease of the newborn, we have the early onset, which is within 7 days. We have sepsis, pneumonia, meningitis of these newborns. Mortality and morbidity is much higher if the patient is preterm, 20% versus 2%. GBS late onset is 7 days to 3 months. The newborn present with bacteremia, meningitis, organ or soft tissue infection. This is more of a horizontal infection from the mother or the community versus a vertical transmission. Risk factors, obviously if the mother is GBS positive, preterm, very low birth rate, prolonged rupture membrane, choreo, young maternal age, African American, prior newborn with GBS, early onset disease. Universal antepartum screening regardless of planned mode of birth. GBS should be done around 36 to 37.6 weeks. Unless patient is already indicated due to bacteremia or history of GBS infection in the newborn. Timing and procedure for screening. GBS screening should be 36 weeks, not 35. It's good for 5 weeks, so it will cover up to 41 weeks. 7% will give birth. Only 7% of pregnant patients give birth after 41 weeks. If more than 5 weeks and it was negative, then you can't rescreen these patients. The swab should be done from introitus to the rectum. Notify the lab if the patient has penicillin allergy. Molecular based versus nucleic acid testing for GBS. Sensitivity similar to culture if allowed to incubate for 24 hours. No susceptibility test can be done. Rapid GBS test is 1 to 2 hours. Sensitivity may vary and 10% failure rate can be encountered. This do not replace the standard culture method. It's mostly for intrapartum use only. Indications for GBS prophylaxis. So pre-labor C-section performed in the setting of intact membrane does not need prophylaxis. If prenatal GBS screening is unknown when labor started, then these who should be on prophylaxis. So these patients are if they are in preterm labor, PPROM, rupture membrane greater than 18 hours at term, intrapartum fever, GBS positive in previous pregnancy at term. 50% recurrent risk versus 15% for prior negative GBS patients. So if they came in preterm labor, we can start the prophylaxis and obtain GBS culture. If the culture comes back negative, we can stop the prophylaxis. We should repeat in 5 weeks. Treating the asymptomatic bacteria is indicated if the colony forming units is greater than, it's not 105, it's 10 to the 5th. It's 10 to the 5th power. If it's less than 10 to the 5th, no treatment unless patient has symptoms. 10 to the 5th is so they need not to be treated. So if the reason you treat asymptomatic bacteremia is because it reduces the risk for pyelo, preterm birth, and birth weight less than 2,500 grams. Indicate on the lab if penicillin allergy for so these can be sent to get Clinda sensitivity. This is now for treating GBS urea. Clinda is very poorly concentrated in the urine. PPROM greater than 34 weeks with GBS positive. If these patients should be induced, it lowers risk for neonatal infection. Planned pregnancy, we should still get GBS screening at 36 weeks. Should be given cefazolin prior to surgery because it does cover GBS. Treatment regimen, if you have no allergy, just do ampicillin 2 gram IV, then 1 gram Q4 until delivery. Allergy to penicillin, if these patients are low risk, you can use cefazolin 2 gram IV, then 1 gram Q8. 5% penicillin allergic 5% of penicillin allergic patients have allergy to cephalosporins. Only 5%. High-risk patient, consider penicillin allergy skin test to determine if penicillin tolerant or allergic. Only 5% of reported penicillin allergy are true allergies. Clinda sensitivities, 20% resistance rate to Clinda. Positive, Clinda sensitive. You can use clindamycin 900 milligrams IV Q8. If they're Clinda resistant, we have to use vancomycin. This is weight-based, 20 milligrams per kilo, Q8 hours, infused over 1 hour, and a maximum of 2 grams per dose. Vancomycin is cleared by the kidney, so creatinine should be done. Duration of a regimen, 4 hours before birth. Has the highest effectiveness. After 2 hours, the body does achieve a bactericidal level in the amniotic fluid. Membrane sweeping not associated with adverse outcome with positive GBS. Mechanical cervical ripening is there's no recommendation as of now. Vaginal exams should be performed when indicated. Artificial rupture of membrane, early amniotomy, and prompt use of oxytocin reduce the rate of C-section and shorter admission to delivery time. Indicated in GBS patients. IU monitoring. GBS positive is not considered a contraindication to intrauterine monitoring. The end.